Good morning to all. First of all, I wish to thank the organizers for giving us this opportunity to chair this session. The first topic is on PCOS. The PCOS is an endocrine disorder. It affects all the women. Of course, 30% of the women in reproductive age group, causing menstrual irregularities, difficulty in conception, hirsutism, and more. It is also complicated with some metabolic abnormalities like glucose intolerance, obesity, and whatnot. So, the treatment for this one is still suboptimal. So, regarding the drug therapy, I welcome Dr. Jayashree Gopal from Chennai, and she is MBBS diplomat of the American Board of Internal Medicine, Endocrinology and Diabetes. Her present designation is Director, Diabetic Endocrinology of India, Associate Dean for Teaching and Research, MEDRC, Chennai. And she is having excellent achievements, Vocational Excellence Award, Rotary Club, Dr. Sam G.P. Moses Oration Award, API Chennai chapter. She had published many research papers, and her particularly this one, altered kinetics of circulating progenitor cells in cardiopulmonary bypass associated vasoplegic patients. This is a pilot study. I welcome you, ma'am.
Good morning, everyone, and thanks to the organizers. So today my topic is what is actually the evidence for the medications that we use in PCOS, and there have been a lot of meta-analysis performed, particularly with use of metformin. So I'll be focusing on some of the larger meta-analysis mainly when I put together this presentation. So at the very core, I think like the chairperson said in the beginning, the PCOS is still a little bit of a mystery. We know some of the things that occur in the pathogenesis, which is an imbalance in the hypothalamic pituitary ovarian signals, which causes a excess ovarian and adrenal androgen production. There is always an additional burden of insulin resistance. So as endocrinologists, we tend to look at the insulin resistance. There is also some lipotoxicity. Definitely there is a lot of oxidative stress because of the excess adiposity. It can be caused by a combination of genetic, environmental, and epigenetic factors, and it leads to not only reproductive but metabolic and psychological consequences also. And depending on what we are trying to treat, so whether we are dealing with just irregular periods or hirsutism, or whether we are looking at infertility treatment, or later down the line, whether they are coming to us with diabetes, I think the implications and prognostication of PCOS is becoming more important. In elderly, then we are starting to think about increased risk of cardiovascular disease and certain malignancies. There are different phenotypes in PCOS, and I just wanted to put this up to say that currently I think in India the most common phenotype that we see is probably phenotype D, which is a combination of ovulatory dysfunction with a polycystic ovarian morphology and ultrasound. We generally do not tend to see excess androgen levels, at least most often in the Indian phenotype. Maybe the clinical androgen excess, but we do not generally see the biochemical androgen excess. So when we come back to what are we exactly trying to treat, I think that determines what type of therapy we're going to do. Are we just trying to regularize the menstrual cycles? If it's for pregnancy, then we need to make sure that they're ovulatory menstrual cycles. If it's not for pregnancy, then it doesn't really matter. We can just do like a withdrawal bleed or contraceptive type bleed. Are we trying to treat skin manifestations, hirsutism, acne, or the frontal thinning of hair? Are we trying to deal with the metabolic consequences, not only the dysglycemia, but also obesity, dyslipidemia, hypertension, fatty liver, sleep apnea? These are all some of the things we need to be assessing for and treating. And there is also a significant emotional component in PCOS, which we sometimes tend to miss or we do not address generally. particularly depression and anxiety, which is being sort of looked at more commonly nowadays. These are the medications that are used commonly, and I'll talk a little bit in more detail, mainly about the metformin among the insulin sensitizers, and among the anti-androgens, more about the estrogen, progesterone, or anti-androgen combinations, and what is the data regarding the couple of ovulation induction medications we use, which is clomiphene and letrozole, and I've sort of classified steroids under others. I will not be talking about the therapies with really not very well proven indications like inositol and other supplements. So this is what I looked at when we looked at the medications. What is it primarily used for, and what is the effect on reproductive outcomes, what is the effect on metabolic parameters. So for example, when we are looking at oral contraceptives, our concern is what is the effect on BMI and metabolic parameters, and when you look at metformin, what is the effect on reproductive outcomes. So I was just trying to see what is the effect on each other's sort of outcomes, and if there has been any significant impact on psychological parameters, and there isn't really much data regarding this, and I'll touch upon it as we go through the talks. So if you look at metformin, currently it is used mainly for the insulin resistance parameters, so for pre-diabetes, diabetes, for reduction of, for example, acanthosis, and of course for weight reduction, though its sort of utility in weight reduction in the absence of diet and exercise is very, very modest at best. We also use it for its effect on regularizing the menstrual cycles, and also to improve ovulation and pregnancy. So if you look at the data regarding the metformin versus various other modifications that we use, various parameters, what is the evidence regarding metformin versus lifestyle modification alone, contraceptive use alone, ovulation induction versus clomiphene or letrozole, other weight loss medications, which I'll touch upon, and other insulin sensitizers. If you look at the evidence regarding metformin versus lifestyle modification, there was a good sort of systematic review and meta-analysis which was published just a couple of years ago. So what is the effect of lifestyle modification alone in PCOS compared to metformin alone, or addition of metformin? And this was the result of all the various studies put together. And I think the most important takeaway message from me from this meta-analysis was that lifestyle modification alone was good at regularizing cycles in up to 2/3 of patients. Metformin alone or with lifestyle modification also improved menstrual cycles in about 50 to 60%, so similar numbers. Weight reduction tended to be the best with diet. Metformin may help to a modest degree. Metformin addition probably causes about a 2 to 3 kilo weight reduction. And diet actually promoted weight reduction much better. So dietary manipulations are very important for weight reduction. Just adding metformin is not going to cause weight reduction unless we also add dietary modification. And there was a suggestion that diet alone may be better than diet with exercise for weight reduction. So I just put this because sometimes, particularly young girls, they get very frustrated, because they're pushing the exercise and they're not losing weight. And, there are many reasons for that. But there was a suggestion that diet actually works better as compared to intensive exercise for weight reduction. But certainly metformin alone is not going to be helpful. And most of these studies define lifestyle modification exercise component as a 150 minutes of aerobic activity per week. And the dietary restriction was reducing the caloric intake to 1,200 to 1,400 calories per day, or a 500 kilocalorie reduction from their baseline. So this was the definition of dietary or lifestyle modifications. What is the evidence of regarding metformin versus CC or letrozole for ovulation induction? Again, this was a good Cochrane review done about 2 to 3 years back. And as compared to placebo, yes, metformin does better. If you don't give any treatment or you give a placebo, metformin fares better. But if you compare it with clomiphene citrate alone, then metformin does not do as well. So obviously clomiphene citrate does better. I think the most important take home from that meta-analysis is that obese women do worse with any form of ovulation induction. Metformin is less effective than or as effective as clomiphene citrate, depending on the parameter. So it doesn't really, if you actually look at the meta-analysis, it is not very effective in terms of ovulation induction by itself. When you combine it with clomiphene citrate, it improves ovulation and pregnancy rate, But interestingly, the meta-analysis did not show any change in miscarriage rate. Though we all have a perception that metformin may reduce the chances of miscarriage, the meta-analysis did not show any difference. All of the study consistently show that up to a third of people have significant GI side effects with metformin, whether it is versus just the CC or in addition to CC. So this is something we need to keep in mind, because I think it impacts upon the sort of compliance with the medication. So if they are going to have significant GI side effects, they do not tend to persist with taking the metformin. Letrozole, I think, is what is being used commonly nowadays. This was again a recent meta-analysis which showed that letrozole actually does better than clomiphene citrate. So though all of the meta-analysis comparing metformin is more the older studies which have compared it with clomiphene, we don't have a large number of studies, but overall I think currently letrozole does better as compared to clomiphene citrate. So probability of ovulation was higher in letrozole as compared to CC cycles, and we do not know whether addition of metformin in a letrozole group does better, like we have the data regarding addition of metformin to clomiphene. We don't yet have the data. How about the use of metformin versus oral contraceptives with respect to skin manifestation? So this is where we would be looking at how does metformin help, for example, with hirsutism. So metformin may perform as well as contraceptive tablets in reducing hirsutism. There is some difference in effect depending upon the BMI, and the data is all over the place. I'm not going into great detail, but definitely metformin tends to have more GI side effects. Usage of OCPs with metformin may actually help to reduce GI side effects, an interesting correlation of or fallout of the meta-analysis which have been done. I think the reverse question was more important for me. What about the effect of oral contraceptives? Does it affect the BMI? And actually the newer oral contraceptives does not increase the BMI or does not lead to much difference in the metabolic parameters. And metformin, again, in the absence of diet, does not really do a whole lot in reducing weight. This was an older study. This is almost like, 15 years old. And what this showed was that metformin versus OCPs both seem to do well in terms of reducing hirsutism. In terms of acne, the oral contraceptive type tablets in this particular case were not the oral contraceptives, but a combination of ethinyl estradiol with the supraterone acetate. It did better with respect to acne improvement. Obviously, the estrogen-containing medicines do better in improving the menstrual pattern and in terms of reducing testosterone levels, whereas metformin will do better in terms of the other metabolic parameters like fasting insulin or glucose or cholesterol or triglycerides. So depending on which parameter we look at, obviously the medication that is used for that did better. But just to point out that in terms of hirsutism reduction, probably there is no big difference between the two if we are trying to decide what it is. But if you're looking at acne, then probably the contraceptive type tablets would do better. There is no long-term data as yet on its effects in reducing risk of cardiovascular disease or malignancies in the long term. And again, another sort of question that is often in our minds is which contraceptive tablet, which sort of combination of estrogen, progesterone, or estrogen and anti-androgen would we like to use? Again, I think it really comes down to as a personal preference. Each one of us has sort of a personal preference, and we think that it works well, and ease of use and what the patient tolerates. So certain sort of progesterones patients do not tolerate because of nausea. The ethinyl estradiol and cyproterone combination may work better at a younger age, and certainly the younger girls seem to find it more preferable in terms of reduction of hirsutism. But we need to keep in mind that it is not approved as a contraceptive in our country, so we cannot use this as a contraceptive, though it does have a contraceptive effect, of course. So these are all some things we need to keep in mind. This was actually a very recent meta-analysis, again published a few months back, which was a network meta-analysis. And this is some very, very complicated statistical manipulation that was done. But basically, the conclusion of this particular meta-analysis was that flutamide actually did better both in metabolic and hormonal parameters. We generally do not use flutamide in our country. I've seen very, very few doctors using it because of a very high incidence of hepatotoxicity, but it seems to do well in improving both metabolic and hormonal parameters. And the cyproterone and ethinyl estradiol combination type of combination did better in improving hormonal parameters. What about metformin versus other weight loss medications? There was a very few studies comparing metformin with orlistat, and again, because of the heterogeneity, I don't think we can really compare. I think some physicians still like to use orlistat, but it showed, some of the studies showed more weight loss with orlistat, 2 showed no difference. All of them showed a significant drop in testosterone and rise in SHBG. So any which way we can get them to lose weight, there will be an improvement in the androgen levels and definitely an improvement in the metabolic parameters. And this was the dosage of the orlistat, 120 mg twice a day or 3 times a day, and metformin dose ranged from 1 gram to 2 grams per day. What about other insulin sensitizers like pioglitazone particularly? No recent analysis. The only one that I could come up with, a meta-analysis, was about 10 years back. And what that showed was that thiazolidinediones are better than placebo, definitely for improving markers of insulin resistance. But by itself, the TZD does not reduce the FG score or androgen levels compared to placebo. Again, this is in contrast to metformin, which does help to reduce hirsutism. And of course, we are all aware that by itself, TZDs may cause some weight gain. But one interesting point that I found in that meta-analysis was that the studies which looked at a combination of pioglitazone with a contraceptive type tablets or anti-androgens, the extent of weight gain was not that much. For some reason, it seemed to retard the weight gain. So just one little takeaway, if at all we are going to consider using pioglitazone because metformin is not tolerated or because they have significant insulin resistance, sometimes we have to consider using it. We can consider using it with some other anti-androgenic measure to limit the amount of weight gain. If you compare metformin versus thiazolidinedione, again, an older meta-analysis, more than about 10-12 years back, I would say there is no really difference between the 2 groups with respect to the ovulation rates, pregnancy rates. However, thiazolidinediones tend to be better tolerated with lesser GI side effects. I think that's the only sort of takeaway. Again, very uncommonly do we use it. I know some centers use it mainly for ovulation induction with good effects. What about newer anti-diabetes medications in PCOS? Very limited data, not really, no meta-analysis, no proven studies. SGLT2 inhibitors currently only approved as an anti-diabetes patient. In small studies done in PCOS with IFG or IGT, it shows only a very neutral effect. It doesn't really cause much by way of weight reduction in this group of pre-diabetes patients. GLP-1RA, again, it is approved for management for diabetes, but liraglutide at a dosage of 3 mg is approved for weight reduction even in the absence of diabetes, and definitely helpful in reducing weight and improving metabolic parameters when used along with metformin in PCOS. Again, small studies, and I think its cost and gastrointestinal tolerability will limit its use, but certainly it definitely has a place in people who are finding it very difficult to lose weight with just diet and exercise alone. One other question that I was interested in looking at was, how do the contraceptive tablets, quite often when we put young girls on contraceptive tablets, they complain a lot about both tolerability issue, and they have a lot of mood disturbances. But in terms of, I think one thing we can take away is contraceptive tablets do not affect the metabolic parameters too much. So they don't affect the lipid profile, they don't affect the weight or the insulin resistance. So we don't need to worry. For example, we see somebody with diabetes or dyslipidemia, unless they have very high triglycerides, that's the only group in which we have to be careful about using estrogen. Apart from that, we don't need to worry about using the contraceptive tablets in terms of worsening metabolic control. Very quickly about the other anti-androgens that we use. Spironolactone, again, no large-scale trials. However, when combined with a COC, definitely better reduction in hirsutism and androgen levels. Very short-term trials. Most of these studies have only been done for a year, maximum maybe 18 months. When used alone, without contraceptive tablet, up to 1/3 experience troublesome intermenstrual spotting. So always in our country, when we use spironolactone, it has to be combined with some sort of a regular withdrawal bleed, preferably a contraceptive tablet. Because no matter what we say, women on spironolactone sometimes do get pregnant, and that becomes an issue. Similarly with finasteride. Finasteride is a competitive inhibitor of the type 2 5-alpha reductase, which converts the testosterone to dihydrotestosterone inside the cell. So one thing we need to keep in mind when we put finasteride is that the testosterone and estradiol levels will tend to rise by 15% compared to the baseline, but they still remain within the normal range while the DHT levels will fall. But there won't be any effect on LH-FSH. Finasteride does not affect metabolic parameters. It may improve hirsutism. Dermatologists generally tend to use it for male pattern androgenic alopecia or frontal hair thinning, and it may help to some extent. However, some of the side effects are breast tenderness, reduction in libido, skin dryness, so higher doses may limit its effect. It's relatively contraindicated because in pregnancy, it's pregnancy category X. Male fetuses develop hypospadias, female fetuses remain normal. One thing we need to keep in mind is that once you stop the finasteride, the effect of the medication on inhibiting the enzyme complex takes about 2 weeks to reverse. So ideally, I would say stop the medication at least 2 months or 3 months before they are even planning pregnancy. And again, it cannot be used by lactating mothers, particularly if the offspring is male. And there was some suggestion that it may also increase the risk of breast cancer if there is a strong family history. This, I'm just putting it up because in case we are trying to think about using it long term, these are all some of the things we need to keep in mind before we consider long-term use of finasteride in women. So let me just go through. Dexamethasone, I find it helpful in reducing hirsutism if there is adrenal hyperandrogenism. It also helps in thinning of hair. It makes the hair thicker, it helps to regularize the cycles. Very, very minimal doses can be helpful. No large-scale studies have been done. We can get away with using like 0.125 or 0.25 mg per day. It's got a very long half-life, so using it even once in 24 to 48 hours also gives a good effect. And when used at minimal doses, really no impact on weight gain or blood sugars. Very helpful, particularly when there is adrenal hyperandrogenism, if the regular anti-androgens do not help. So the treatment options for hirsutism, as you can see, are very varied. Depending on what it is we are trying to treat, we have various options available. If you're just trying to restore the periodic menstrual cyclicity, we can use either progesterone withdrawal or contraceptive or ethinyl estradiol or cyproterone or ethinyl estradiol and drospirenone combination. We can consider using insulin sensitizers alone, but they would be a second choice. When we are looking at reducing androgen excess, particularly with respect to its effect on hirsutism and acne, first choice always remains anti-androgens. Finasteride can be used, spironolactone can be used, flutamide, generally we do not use. Insulin sensitizers, metformin has been shown to reduce hirsutism. Improving insulin sensitivity, very definitely insulin sensitizers help. Anti-androgens do not hurt, they do not make it worse. Ovulation induction, the shift is towards using letrozole in general, combined with insulin sensitizers, particularly if there is pre-diabetes. So finally, the treatment of PCOS is personalized, and I think it depends on the most pressing issue that the woman has at that point. Lifestyle modification, good diet and exercise always necessary, and no one medicine is a cure for PCOS. Thank you.
It was an excellent talk. You almost covered everything. Thank you. Thank you.
Thank you, madam. Thank you very much for your insight view on the drugs which can endocrinologist in male infertility. Today, we are pleased to welcome Dr. Anjali Satya, a very special guest from Chennai. Anjali Satya, she is a MD DNB. Present designation is Consultant Endocrinologist, Vijaya Group of Hospitals, Apollo Specialty Hospital, Vanagaram. Her interest is on diabetes, thyroid disorders, reproductive endocrinology, achievements in clinical practice for more than 15 years, and many publications in the national and international papers. And today, she will be sharing with us her expert opinion on male infertility as an endocrinologist. We know the sperm is the most brilliant cell in the body because it has to leave the male partner, enter into the female partner genital tract, where it has to survive the hostile environment, hopefully reaching the ovary and fertilizing to form a baby. So as an endocrinologist, how Madam is going to help us to improve the count and motility we can see. Over to you, Madam.
Thank you, Chairpersons. At the outset, let me thank my Trendo team for inviting me here. It's a great opportunity and honor to be on this platform and to present this topic on male infertility and what is the role of an endocrinologist in male infertility. So this is the male reproductive system. The spermatogenesis occurs in the testis, and then the sperms go to epididymis, where they undergo maturation, and the sperms acquire motility and fertilizing capacity in the epididymis. So they spend some time there. Finally, the sperms are transported via the vas deferens, and they go on to the ejaculatory duct. So let us familiarize with the hypothalamo-pituitary testicular axis. The GnRH neurons secrete GnRH from the hypothalamus, which acts on the anterior pituitary gland that secretes the gonadotropins. The FSH acts via FSH receptor onto the Sertoli cells and initiates spermatogenesis. The LH hormone, the luteinizing hormone, it acts via the LH receptor, works on the Leydig cells, and leads to testosterone production from androstenedione. Now, as in any endocrine axis, the target organs and the hormones secreted exert a negative feedback both on the pituitary and the hypothalamus. So when we look at infertility as a problem, almost 1 in 6 or 7 couples face this. 40 to 50% could be attributed to the woman, and 30 to 40% can be attributed to male factors, and about 10 to 11% could be combined. Both men and female may contribute to the fertility issues, and there is a significant number with unexplained infertility. Now, what do we define infertility as? Infertility is usually defined as the inability to conceive in spite of 1 year of unprotected sex. And this duration is reduced to 6 months if the woman is older than 35 years. So if the wife is older, you don't wait for 1 year. You can start evaluating even much earlier. Now, what are the 3 basic elements of male fertility? One is the ability to produce normal sperms in the testis. And that would depend on the presence of normal germ cells. It would also depend on intact Leydig cell and intact Sertoli cell function. The Leydig cell secretes testosterone that leads to high testosterone level within the testis. It's almost 100 times more than the serum levels of testosterone. And this high intratesticular testosterone is required for normal spermatogenesis. FSH, the Sertoli cells acts as a nourishing cell. It gives the correct milieu for spermatogenesis. So you need normal LH-FSH or normal hormonal stimulation for an intact spermatogenesis. And the third important factor is, after spermatogenesis is over, you need a patent functional transportation system from the testis to the ejaculatory duct. So if you have a pathology there, again, infertility. So an infertile men with an abnormal semen analysis will have these reports. So I'm just familiarizing with the terms. Oligozoospermia is a low number of sperm cells in the ejaculate. Azoospermia is absence of sperms. And whenever we document azoospermia, it is important to repeat one more sample within few weeks, not months later, because the spermatogenesis cycle is about roughly 2 months. Asthenozoospermia is where you have abnormal sperm motility, and teratozoospermia is where you have abnormal morphology in sperms. So you may come across these terms in semen analysis reports. Some infertile men have normal sperm counts. Now I've put up this table to basically say where the role of endocrinologist comes. So we can divide these causes of male infertility as pre-testicular causes, which would be essentially the signals coming from the hypothalamus and pituitary. So any pathology there is dealt with by an endocrinologist. The testicular causes would include varicocele, genetic factors, cryptorchidism, and exposure to gonadotoxins. This would also involve chemotherapy and radiotherapy-induced damage. Post-testicular is pathology that is involved in the transportation system, in the obstruction in the duct, vas deferens, or absence of vas deferens, or ejaculatory duct obstruction. And disorders of ejaculation and erectile dysfunction also comes in this category. So the role of an endocrinologist is mainly in the pre-testicular causes and also in erectile dysfunction and some disorders of ejaculation. So let me go in detail. The pre-testicular causes, mainly what I would discuss is the hypogonadotrophic hypogonadism. This could be congenital, as in Kallmann syndrome, where there is congenital GnRH deficiency, iron overload syndromes. This is one very important cause for hypogonadotrophic hypogonadism. This could be following recurrent transfusions or hemochromatosis. Multiple genetic syndromes like Prader-Willi, Lawrence-Moon Beadle, all these syndromes are associated with congenital hypogonadotrophic hypogonadism. Acquired disorders would involve tumors. It could be infiltrative disorders. It could be a trauma. It could be a hypophysitis. It could be vascular causes like pituitary infarction or aneurysm, or hormonal. We had a very extensive session on hyperprolactinemia, and hyperprolactinemia is one very important cause for secondary hypogonadism. Drugs, very, very important. We need to take a very detailed history to elicit this. And systemic disorders like severe systemic illness. That is why we say that we should never evaluate a very sick person for sex hormone levels, because that's a time when the GnRH is suppressed. Nutritional deficiencies and morbid obesity. Primary testicular defects, we do not have much role. In Klinefelter syndrome, which is the commonest congenital cause for hypogonadism, cryptorchidism, myotonic dystrophy, you can have androgen insensitivity syndromes, 5-alpha reductase deficiency, and estrogen receptor or synthesis disorders, where the scope for medical treatment is not very great. Other acquired causes can be varicocele, infections, drugs again. The importance here in drug-induced testicular injuries that before we administer chemo or radiation, there is a scope for fertility preservation. I'll come to that later. Immunologic disorders, trauma, or testicular torsion. I would also like to stress on systemic illness. Somebody who is very sick or who has systemic disease like renal failure, chronic liver disease, sickle cell anemia, vasculitis, celiac disease, all these can be associated with suppressed spermatogenesis. Genetic causes of spermatogenesis, again, have to be evaluated in any man with infertility, especially Y chromosome microdeletions and related disorders, and some mutations can cause severe defects in even sperm morphology. Transport disorders, we can encounter either absence of vascular vas difference or epididymal dysfunction, or you can have ejaculatory duct obstruction. Sexual dysfunction is a very common etiology in regular practice. Many men, they do not report erectile dysfunction until they come to the fertility clinic. Till that time, they sort of, they go through it and they don't take treatment for the same. And that can be a very major cause for infertility. Infrequent sex, erectile dysfunction, and premature ejaculation. And certain factors are still unknown. So that is classified as idiopathic. So the essential components of evaluation of an infertile man would be a good history, physical examination, and the most important thing is a semen analysis. The additional components would involve endocrine testing in a select group of cases, imaging of the accessory glands and ducts, which would include a transrectal ultrasound for ejaculatory duct visualization, or a plain ultrasound scrotum for scrotal and vasculature of the testis. Genetic testing is mainly to rule out Y chromosome microdeletions. Now, how do we triage and refer to an endocrinologist? History itself may give us some clue. Especially, we need to look at the sexual developmental history, whether they have had cryptorchidism, undescended testis as a child, whether they had undergone a surgery for the same, delayed puberty, loss of body hair, or decrease in shaving frequency. The clinical manifestations of androgen deficiency depends on the age of onset. So if you're dealing it in early childhood or infancy, it would present as ambiguous genitalia, or in late gestation as micropenis. In childhood, it is present as delayed puberty. In adulthood, as decreased sexual function, poor libido, infertility, and loss of secondary sex characters. Physical examination, one must look at the skin. Sometimes that may give us a clue. So a man who comes with, say, generalized hyperpigmentation, it may be an underlying clue for an iron overload syndrome like hemochromatosis, which can cause hypopituitarism. They can have thin bruising skin, and if they have Cushingoid features, we must evaluate them for Cushing syndrome, which again is a cause for secondary hypogonadism. Loss of pubic, axillary, facial hair, decreased oiliness of the skin, fine facial wrinkling could suggest a long-standing androgen deficiency. Now, most of this time, what we find is many men with androgen deficiency do not report to physicians. They come only at the time of fertility evaluation. External genitalia examination is a very important aspect of physical examination, where one needs to examine the phallus size, the testicular volume. We use a Prader orchidometer for the same. In an adult man, if you have a testicular volume less than 15 ml, or a testicular length measured on the longest axis less than 3.5 is considered small. So let us familiarize with the basic semen analysis parameters. The patient is asked to masturbate in the clinic, or even a home collection is fine, but it should be analyzed within 1 hour. So it should not be transported to a laboratory that takes a longer period of time, which may sort of cause a lot of gross changes in the results. So you look at the semen volume and pH. A low volume and a low pH, acidic pH, may actually indicate obstructive cause. Microscopy for sperm concentration, count, motility, morphology. One also looks at the agglutination. Agglutination may actually give a clue to presence of sperm antibodies. Leukocyte count, which is suggestive of infection, or immature germ cells. So these are the lower limits of normal. So if you have a volume less than 1.5 ml, abnormal. Sperm concentration less than 15 is considered very, very low. Total sperm numbers, 39 million. The bracket mentions the confidence intervals. Morphology, at least 4% should be normal forms. They should be motile. Motility should be at least 40%, 50%, and progressive motility to at least 32%. And the total progressive and non-progressive motility put together should be at least 40% in a sample. Endocrine testing is usually offered to men who have very, very low counts, less than 10 million, or severe SOT. It's called severe oligoasthenozoospermia. In those individuals, we have to ask for a fasting total testosterone levels, FSH, LH, prolactin, and others as indicated depending on what we are suspecting after a clinical examination. Now, total testosterone should be always tested in a fasting sample, and if we document a value less than 3, it's considered abnormal, but we should always repeat a second sample for testosterone before declaring that individual to have testosterone deficiency, which can be collected a week or 2 apart. If you have low testosterone and high gonadotropins, high FSH and LH, which means that the testis is not responding. This is what we see classically in a primary hypergonadotrophic hypogonadism. And here we think of the commonest cause, which is a genetic cause, Klinefelter's, or it could be also due to a testicular injury. So here we have to ask for karyotype, especially when we see low testosterone and high FSH and LH. If we find normal testosterone and normal LH with only high FSH, it is suggestive of primary hypergonadotrophic hypogonadism, but without Leydig cell dysfunction. Here we have a normal LH, that means the Leydig cell function is normal. If we find a low testosterone but FSH and LH not elevated, if they are normal or low, this is what we classically see in hypogonadotrophic hypogonadism. We should think of hypothalamic or pituitary cause for hypogonadism. And we always look for secondary causes, and hyperprolactemia is a very common cause for secondary hypogonadism. We should also assess them for their thyroid functions, do the other anterior pituitary functions. If prolactin is elevated, we also ask for cortisol and do a cellular imaging. Cellular imaging is offered to all men with documented hypogonadotrophic hypogonadism to rule out tumors or empty cella, etc. If you have a high testosterone and LH but normal FSH, this could mean that the individual may have a partial androgen resistance. If you have all parameters normal but the man is infertile, then a further decision would depend on the semen analysis findings. And if azoospermia is present, we have to classify them either do they have obstructive azoospermia or a non-obstructive azoospermia. So let us go through some case scenarios which will throw more light on an endocrinologist's role or where we cannot offer them help. So I thought I would present both the cases scenarios. The first case is a 30-year-old man who comes with severe headaches and was on analgesics for same, married for 1 year. He has had erectile dysfunction but has not consulted any doctor. He has been experiencing weight gain, severe fatigue, and always felt less energetic. He was asked to do imaging because he had headaches, and the MRI brain revealed a cellular mass. Now, retrospectively, after finding that he had an cellular mass, the hormone evaluation was done. On examination, he was obese, reduced facial and body hair, he had no gynecomastia, and external genitalia examination showed a normal penile length, testes were normally positioned, normal consistency and normal size. There were no evident abnormalities of the epididymis or the vas difference. On evaluation, he was found to have anemia, hemoglobin of 11 grams. His free T4 was low, 0.6, and TSH was 2. His cortisol was also low, and prolactin was more than 200. Now, we had, in the first discussion, I think they had spoken about high-dose hook effect. Whenever we see a very high prolactin level, we think of above 200, we have to think of tumoral cause for hyperprolactinemia, and in dilution, the titers were found to be 3,300. Testosterone was suppressed because of the hyperprolactinemia, because high prolactin suppresses the GnRH hormone secretion, and that leads to secondary hypogonadism. This slide, previous slides. Next slide. Yeah. Yeah. So I'll go on with the presentation. So this individual had a high prolactin and he had a low testosterone. And when we checked the FSH and LH, they were also found to be suppressed. The FSH was 2 and LH was only 1.8. The semen analysis revealed azoospermia. So here we have a young man who had erectile dysfunction for a very long time. Because of his headaches, went for an MRI imaging, found a cellular mass. Retrospectively, he was diagnosed to have a macroprolactinoma. The MRI showed the following findings. So I think I'll just display the image. So this individual was diagnosed to have macroprolactinoma and he was started on cabergoline. Now we do not know how long this macroprolactinoma was sitting. So cabergoline was initiated and after 6 weeks his prolactin dropped down to almost like 30 nanogram per ml, but his testosterone remained suppressed. So in this individual, cabergoline therapy alone is not going to restore his fertility because we do not know how long was the duration of the macroprolactinoma. So the MRI shows a macroprolactinoma. He was offered cabergoline therapy. The prolactin levels dropped to 30 within about 6 weeks' time. So the values crashed from 3,000. That's the kind of response we see with cabergoline. And sometimes these patients, due to rapid shrinkage of the tumor, sometimes can develop CSF rhinorrhea, which was discussed in the morning. Now, this individual had resolution in prolactin levels, but the repeat MRI after 2 months did not show much decrease in size. And he also had visual field defects on visual field charting, and hence he was offered surgery. After surgery, he was started on full hormone replacement therapy, both thyroxine, hydrocortisone. He was put on injection HCG 5,000 units twice a week. This was added to stimulate spermatogenesis. He was married only for 1 year, and this was important because cabergoline therapy alone here will not restore spermatogenesis. So he was started on gonadotropin therapy also. The second case is an 18-year-old young man who was recently diagnosed to have Klinefelter syndrome. He had 4 ml testes bilaterally, and the karyotype revealed 47XXY. He had eunuchoid body proportions on clinical examination, where the arm span is greater than the height. He had gynecomastia, but he had mild facial hair, axillary and pubic hair. His testosterone was on the lower limit of normal, 3.06. LH was elevated and FSH was elevated. So this shows that this individual had hypergonadotrophic hypogonadism, and they wanted to mainly discuss his fertility potential. Now, what is notable is his testis is only 4 ml, and in Klinefelter syndrome, the small testis usually undergoes hyalization, and the retrieval of sperms can become very difficult. So small testis and azoospermia is seen in more than 95% of patients with XXY, and only in certain select cases, especially Klinefelter mosaic, where you have both XY and XXY, there is a chance that they may have sperms in the semen, and there is a scope for microtessa, or microdissection of testicular sperm extraction, and ICSI can be offered. The fear for aneuploidy in the infant is not there, because only those germ cells will produce sperms which are euploid in this mosaic scenario. So microtessa can be offered in a select scenario. This may not be useful if testicular volumes are low. So here the parents had to be counseled, and he was put on testosterone replacement. The third case is a 35-year-old pharmacist who was referred from a fertility clinic. He already had a 10-year-old son, but no children from second marriage. He reports decreasing libido, decreasing energy levels, and found to have low testosterone levels. He also used to do regular workouts at gym, and he has been having mild arthralgias. Other than that, he never had any other systemic complaints. He denies taking alcohol, anabolic steroids, or other drugs. On examination, he was a muscular man with normal secondary sexual characters, BMI of 24, not Cushingoid, skin was normal. Genitourinary examination revealed a testis of 15 ml, otherwise there was no other remarkable features. Biochemistry showed low testosterone, 1.5, prolactin was normal, thyroid functions were normal, gonadotropins were on the lower side, 3 IU, both for FSH and LH. Cellular MRI did not reveal any cellular mass lesion. Because of the arthralgias, X-ray hands were asked for, and that showed chondrocalcinosis, which is seen in this image, basically calcification of the chondrocartilage, which is seen along the edges of the bones, and this is classically seen in hemochromatosis. This individual had his ferritin checked, it was found to be more than 1,000. So he had not had a skin manifestation. Normally in hemochromatosis, these people can come with diffuse hyperpigmentation, which can be a clinching factor for diagnosing hemochromatosis or iron overload state. But he had chondrocalcinosis, which is very important, especially in a younger man. You see chondrocalcinosis, you have to think of hemochromatosis. So final diagnosis was a hereditary hemochromatosis with hypogonadotropic hypogonadism. Even other hormone axes can be involved in hemochromatosis. They can also present later with diabetes or liver damage. But this individual had presented early, so his other organs were relatively normal. Fourth case is, again, a 27-year-old married for 1.5 years. He came with his wife, reported erectile dysfunction. This had affected their marital relationship. He had occasional headaches, gained more than 10 kilos in last 2 years, led a sedentary lifestyle. He was an IT professional. BMI was in obesity range. He had strong family history of autoimmune thyroid disease. Both his mother and sister had thyroid problems. Otherwise, he had no specific complaints. On lab investigation, he was found to have anemia with a high MCV. The red blood cells are usually large in hypothyroidism. Sugars were in the impaired fasting range. Lipids revealed a mixed dyslipidemia, showing high total cholesterol of 245 and even high triglycerides of 350, a low HDL, which is classically seen in sedentary individuals. TSH was asked for because he had a strong family history of autoimmune thyroid disease, and also he reported erectile dysfunction. So men with erectile dysfunction, we should evaluate them for thyroid function and prolactin. That is what I want to, as this is the carry-home message from this slide. The TSH was found to be more than 150 and free T4 was low. Prolactin was also found to be elevated, but here we consider it to be a secondary hyperprolactinemia, which is encountered in severe hypothyroidism. But if you notice, the prolactin is elevated to a moderate degree. He got his MRI done because he has been having headaches also, and the MRI revealed a cellular mass. So here we have a young individual with severe hypothyroidism, has moderate degree of prolactin elevation, and MRI shows a cellular mass. But here we have to be careful because severe hypothyroidism, when TSH, when T3, T4 are very low in the blood, as I said, there will be an elevation in TSH as well as TRH. So there is thyrotrope hyperplasia, and the pituitary undergoes enlargement because of the thyrotrope hyperplasia. Once we treat this individual with thyroxine, this cellular mass can actually reduce in size. So here we should not offer surgery. So this is known as a pituitary pseudotumor, which is commonly seen in people with severe hypothyroidism. I just wanted to discuss this slide for, he also had erectile dysfunction. The commonest cause for erectile dysfunction is stress and psychogenic. The endocrine causes are hypogonadism of any cause, low testosterone, diabetes mellitus, hyperprolactinemia, and hypothyroidism. So that is where our role is. And this is how we treat. The treatment of erectile dysfunction, we have to assess and modify the lifestyle risk factors, especially sedentary lifestyle. They should be advised to exercise and lose weight, avoid heat exposure. The hormone disorders I had already mentioned in the slides, and we have to counsel the patients and the partner. The medical therapy is limited to offering them phosphodiesterase E inhibitors, 5 inhibitors, especially sildenafil and tadalafil. Some of them get relief. Now, if a man comes with infertility and severe erectile dysfunction, offer them treatment for erectile dysfunction first, because that itself may cure his fertility issues. And if in spite of correcting erectile dysfunction, he does not achieve pregnancy, the couple do not achieve pregnancy, then we have to go further in further evaluation. So treat the erectile dysfunction first before treating the subsequent problems. The fifth case is a 35-year-old man evaluated for infertility. He had normal libido, erections, not on any medication or drugs. His wife has regular cycles, so normal people, but they were infertile. He had normal secondary sexual characters, no gynecomastia, testicular volume was normal. Labs revealed normal testosterone levels and normal gonadotropin levels. So here is a normal man who has come with infertility issues. Semen analysis showed a low volume and an acidic pH. It showed azoospermia. Azoospermia, as I mentioned earlier, should be confirmed on a repeat analysis. So the low volume and low pH indicate obstructive etiology here. And this patient on clinical examination was found to have bilateral absence of vas difference, which was confirmed on an ultrasound. And when we get bilateral absence of vas difference, which is congenital, we have to do genetic testing for the cystic fibrosis, transmembrane conductance gene, and other organs may also be involved in this case. But bilateral absence of vas difference is a very important cause for obstructive azoospermia. Now this table demonstrates various causes for non-obstructive azoospermia and obstructive azoospermia, and one endocrine test which can sort of help to differentiate the two is estimation of FSH. If FSH is normal and patient is azoospermic, we are dealing with obstructive in most cases. If FSH is elevated, we are dealing with testicular cause. Y chromosome microdeletion, again a very important cause for non-obstructive azoospermia, where the man may have low testicular size due to disruption of spermatogenesis, high FSH, and they can present, and there is a factor called azoospermia factor, which is localized on long arm of Y chromosome, and there are different subsections. AZF A factor deletion leads to complete tubular atrophy, so low testicular volume. AZF B leads to only Sertoli cell only syndrome. Leydig cells are lost. AZFC causes 80% of Y microdeletions. Here again, endocrinologists do not have a role to play. And the last case is a 32-year-old man with already diagnosed panhypopituitarism because he had a resection of non-functioning pituitary macroadenoma at the age of 28 years. He comes to the fertility clinic. He has been on testosterone replacement from the time of surgery. He is also on hydrocortisone and thyroxine. His wife has regular cycles. So here we know that it's a man who is on having hypogonadotrophic hypogonadism, but he's on testosterone replacement. On examination, his BMI was 30 and BP was normal, well androgenized because of the exogenous replacement therapy, and testis was 15 ml bilateral. Testosterone levels were fairly good, 4.4 nanogram per ml. Thyroid functions were normal, but the semen showed azoospermia. The diagnosis was post-pubertal acquired hypogonadotrophic hypogonadism, and the azoospermia here is because of the testosterone replacement therapy. So once someone is put on testosterone, it's like a contraceptive effect. The spermatogenesis is suppressed because of testosterone, and when such an individual desires fertility, we have to switch over from testosterone to gonadotropin therapy. So that is a message from this slide. In fact, any man who has hypogonadotrophic hypogonadism, if he is desiring fertility, never put them on testosterone, rather start them on HCG therapy. Now, exogenous testosterone therapy suppresses the FSH and therefore spermatogenesis, but that is important to achieve high intratesticular testosterone levels. So once we stop the testosterone, we put them on HCG, which is a long-acting LH analog. The dosage that we normally start off is 2,000 units, can be given sub-Q or IM thrice a week. And then we have to repeat the semen analysis of every 2 months and repeat the testosterone levels. If the testosterone levels are achieved between 4 to 8, the dosage can be maintained, or if it is not maintained between 4 to 8, then we step up the dose further to something like even 10,000 units per week. So monotherapy with LH may suffice for people who have acquired hypogonadotrophic hypogonadism because their testicular volumes are good. Testicular volume normal means seminiferous tubal compartment is intact. If they have very low testicular volume or lesser or lower testicular volume, we may have to add FSH in the beginning itself. So we have to add HMG that is offered as starting dose is around 75 IU. That may not suffice thrice a week. We may have to step it up to 150 units thrice a week. So sometimes dual therapy is offered in men to get faster resolution of spermatogenesis. Once HCG is started after switching over from testosterone, it takes roughly 6 to 9 months for spermatogenesis to happen. So we have to tell the patients that it will take time. Otherwise, when they are about to get married, I think the role of endocrinologist is to counsel them ahead of time. We start them on testosterone replacement when the diagnosis is made, and once they get married, we switch them over to HCG. So it may take 6 months for spermatogenesis to resume, and if we give dual therapy with HCG and HMG, the results can be faster. So testicular size is a very important surrogate of fertility potential. Men with congenital hypogonadotrophic hypogonadism, like in Kallman syndrome, with lower testicular volumes, they need HCG and HMG from the beginning. But very low, less than 4, prognosis is very poor, and that should be explained to them, and fertility is not possible. To summarize, male factor as cause for infertility is very common in clinical practice. Role of endocrinologist is limited to evaluation of men with hypogonadotrophic hypogonadism, both primary and secondary. Secondary causes, we treat the underlying cause. Erectile dysfunction or some men with premature ejaculation. Medical therapy is successful in patients with hypogonadotrophic hypogonadism with reasonable testicular volumes. Those who have hypergonadotrophic hypogonadism, they have to go for a donor sperm program. People who are obese and have lifestyle issues, they have to be counseled for weight loss. Drug or substance abuse is a very important cause. So if they have history of alcohol intake, smoking, all that can affect fertility potential. They are important reversible causes for subfertility. One important thing which I want to highlight is fertility preservation, though it's beyond the scope of presentation, but people who are going to go for chemotherapy or they're undergoing radiation for lymphomas which are diagnosed early in life, we can offer them fertility preservation. Now we have people with gender dysphoria who are wanting to undergo hormone therapy for gender change. Even they have to be counseled for fertility preservation before, so their eggs or sperms can be cryopreserved before they undergo a permanent irreversible hormone therapy to So in transgenders also, I think that is a very important role to play. So endocrinologists have to counsel them ahead of time so that we are able to preserve their fertility. With that, I conclude, and questions are welcome. Thank you.
Thank you, madam. Thank you very much for your expert opinion.